It's really a great pleasure and my honor to speak to you today for the National Kidney Foundation. I really enjoy my visits to China. Too bad that this year I could not be there physically, but we all understand that. And again, it's a great opportunity for the nephrologists in the US to collaborate with you in China who do such great groundbreaking work in the field of nephrology. So again, it is my great pleasure to represent the NKF from the United States. So I was going to speak about one of our sessions, which was about hypertension in special populations. So I'm going to concentrate on three different talks, one about hypertension in the elderly, one about resistance and mostly refractory hypertension, and finally about hypertension in hemodialysis patients. So I'm going to go ahead and start with my talk. And one of the first questions that we have because of the SPRINT trial is, what should our goal blood pressure be for a 79-year-old patient with a blood pressure of 140 over 88 millimeters of mercury? Should it be at the AHA goal of less than 130 over 80? Should it be less than 140 over 90? Or is it C? It depends. Now, I'm going to argue that it really does depend on how healthy our 79-year-old patient is. Are they very healthy, they can independently live, or are they really someone who needs help to get out of bed? Do they have a lot of comorbidities? So again, this is the SPRINT trial, and really it's looking now at SPRINT Senior, where we have adults greater than 75 years old, again, randomized to the SPRINT blood pressure goal of less than 120 versus less than 140. And our primary outcomes are cardiovascular, myocardial infarction, non-fatal stroke and heart failure, or death from cardiovascular causes, with a secondary outcome of all-cause mortality. So what's very important is our exclusion criteria. So remember, everyone is over 75 and they do not have diabetes, stroke, or heart failure. So that was usually with the SPRINT trial, we all know that. But in the SPRINT Senior trial, there were additional criteria. You could not be in a nursing home. And I know in China, this is very rare, but in the US and Europe, once one of our elderly patients is not able to care for themselves, there is this tendency to put them in a nursing home. So these are people that cannot live independently. It's very different culturally. In the US, again, the parents and grandparents are not cared for by the family. The patients could not be demented. They could not have orthostatic hypotension. They were had to be expected to survive greater than 3 years. And again, they couldn't have any weight loss. So all these were criteria for getting into this SPRINT Senior trial. And I hope that at the age of 75, I'm able to get into this trial because again, this is a very healthy population. Okay, so when we look at the outcomes, the cardiovascular outcome, all-cause mortality, primary and secondary, we can see that the intensive arm, those that had blood pressures by SPRINT blood pressure readings less than 120, did much better than the standard treatment group, the standard blood pressure goal group. Okay, and this was statistically significant. Now, one question might be, well, what about people who were healthy, but maybe what about people who are a little bit more sick? Were the people who were a little bit more sick, were they going to do just as well with the lower blood pressure goal? So here is something where they use this FI, this is this fit index, excuse me. So for those that are very fit, we can see that, again, this is the cumulative hazard of cardiovascular outcomes. The intensive arm was less than the standard treatment arm. Again, there was a very few people, the hazard ratio was here, but it crossed the midline. Not statistically significant, but the thought was if you had more people, you would see this. Less fit, again, this index between 0.1 and 0.21, again, it does seem that the intensive group did better. Now the question is, would those that are frail, those that were a little less healthy, would they do as well? And what we can see again is the hazard ratio is lower for the intensive group. Okay, did not quite reach statistical significance. But again, the thought was, gee, even in the frail group, they would do better with intensive blood pressure control. Okay. So the AHA guidelines say that for those that are over 65 who are ambulatory and again, independently living, we should use the same blood pressure goal as we do for younger patients. However, if the patients have a lot of comorbidity, then perhaps we need to really think about the goals and really what are we expecting from these patients. So why did they say that? Well, this was again the SPRINT trial with this frailty index, and we can see the percentage of patients, and this black line is the number of SPRINT patients. So we can see that, again, if you were less fit or fit, there was a fair number, but over their 0.2 frailty index, there were a fair amount of people that were in this category. So again, by the SPRINT trial, they're saying that, look, really, we should be using this for, in our trial, people who are frail. Now, one thing that they really don't explain very well, I think, is that, again, this was a group that was independently living. You really did not have that many people that were very ill. So when you actually look at this index and you look at studies that look at very frail or the most frail patients, this number is greater than 0.45. And we can see that in the SPRINT trial, again, they were independently living. There were very, very few people that would have met that criterion. Okay. So what if we look at patients that are not fit, that are really in that very frail category? So this was an observational study in Europe of patients that were greater than 80 years old, who again reside in nursing homes. They cannot live independently. Okay, so they looked at all-cause mortality by systolic blood pressure level and the number of medications. So would this group do as well as the SPRINT people, the SPRINT senior group? Would they do as well? And what we can see is actually they do not. This is the survival rate. And this is the group that had a low blood pressure, less than 130, with more than one medication. So this is their survival versus all other groups. Now, again, this was an observational study, but it's very important. The SPRINT senior trial looked at very healthy, for the most part, patients who are elderly. So what about kidney outcomes? So again, intensive versus standard, acute kidney injury, there is a larger hazard ratio, almost crosses 1, but is not statistically significant. For those with chronic kidney disease, we see that there is a reduction in GFR, dialysis transplant, again, a higher hazard ratio in the intensive arm, but not statistically significant. And here's albuminuria. So if you had CKD, again, there was this thought that there was a not statistically significant worsening for these outcomes. But what if you had no CKD at baseline? So this group had a significant hazard ratio for having kidney events that are defined here. A 30% decline in GFR to less than 60, dialysis or transplant. Now, not many patients were in this category, but this was statistically significant. So if we're going to shoot for that lower goal, we as nephrologists, of course, have to look at the kidney outcomes as well. The thought is, well, you'll take some of this outcome if patients live longer and don't have cardiovascular death. So again, it's a little bit of a balance. These are just some studies that look at the elderly, looking at goal versus achieved blood pressure. Okay, so here's intensive control, here's standard control, and here are kidney outcomes. And we can see that it seems that when you go for the lower blood pressure goal, you sacrifice some kidney outcomes. All right. Another thing that we may really want to think about in those that are very healthy, and perhaps when you and I become older, is we want to try to prevent dementia. So again, the Sprint Mind study looked at this for dementia. Here's other studies looking at basically the lower goal versus the higher goal. And again, in these healthy elderly people, it seems that the lower blood pressure goal was better for preventing dementia. Now, in those, again, who are not independently living, who are sicker, there is some evidence that does not follow, that in fact, those patients may have worse outcomes. When we talk about blood pressure medications that we can use, a lot of our elderly patients, they have arterial stiffness, they might have isolated systolic hypertension, and thiazide and calcium blockers are good initial first-line treatments. For those with chronic kidney disease or heart failure, we might use an ACE inhibitor or ARB. And for those with ischemic heart disease, again, a low ejection fraction, you can use beta blockers as well. Okay? And here are some of the risks with all these therapies. Now, is there, again, perhaps a better blood pressure medication to prevent dementia? Something that, again, I personally would be very interested in. Okay? So this was a recent publication in JAMA, okay, looking at patients who are older and looking at dementia. So this is comparing an ACE inhibitor to an ARB. Now this is a task. So the lower the number, the faster you do this, the thought is the better cognitive ability you have. Okay? And what we can see is that after 12 months of candesartan for lisinopril, the candesartan patients seem to have a better mental status than the lisinopril patients. Okay? They also looked at MRIs, and they looked at white matter lesions through time. Again, here's candesartan, and here's lisinopril. The lisinopril group had more white matter changes, and something that we'd like to avoid to prevent dementia. So it really seems that ARBs are better than ACE inhibitors for preventing dementia, for preserving our cognition. Now, why does that occur? And this had been noted before in some observational studies. So the explanation appears to be that an ARB selectively inhibits the angiotensin 1 receptor, whereas an ACE inhibitor will block both the angiotensin 1 and the angiotensin 2 receptor. The angiotensin 2 receptor is responsible for neuronal axonal generation, for neuronal repair, and also for decreasing inflammation. So with an ACE inhibitor, you might be knocking out these good parts by blocking the AT2, whereas with an ARB, you only block the AT1 receptor. Okay. So now I'm going to shift to resistant hypertension by Dr. Aldo Peixoto of Yale University. And I'm going to concentrate more of my talk on when he talked about not just resistant, but also refractory hypertension. Okay. So for Dr. Peixoto, resistant hypertension is an increased blood pressure despite 3 medications, including a diuretic. And we know that most of these patients have fluid retention. So these are about 10 to 20% of patients in the US who have hypertension. They're usually older, they can be diabetic, they can have CKD, and really fluid retention is one important mechanism for this. And he broke this down into patients who are intolerant of medicines, but then he also talked about refractory hypertension. So these are patients that have an elevated blood pressure despite 5 medications, including thiazide diuretics and mineralocorticoid antagonists like spironolactone. And they seem to have an increased sympathetic activity. So this might have been 5 to 10% of the patients who have resistant hypertension. From the hot trial in China, it's felt that 2.5% of patients with hypertension might have this refractory hypertension. So it's not really common, but they are very, very difficult to treat. Now, people that have refractory hypertension are different than those with resistant hypertension. They tend to be younger, more obese, and they have more cardiovascular side effects. They tend to have strokes and heart failure. Again, the thought process is it's not as much fluid retention here. It's more increased sympathetic activity. And he talked about how we might treat these patients. Again, we have to make sure our patients adhere to their medications, that they're taking their medications. And Dr. Peixoto stressed the use of the 24-hour ambulatory blood pressure monitor. And again, we might talk about therapy here in the end in this group. Okay, so again, adherence. Are patients taking their blood pressure medicines? In that resistant group, it's felt that up to 60%, if you measure urinary levels of drug, pill counts, 60% of patients don't take their medicines or don't take the dose of their medicines they are supposed to. So we have to make sure in those that have resistant hypertension, they are taking their medications properly. Okay. Now, he then talked about the use of the 24-hour ambulatory monitor. So in resistant hypertension, again, fluid overload, 3 drugs, the white coat effect seems to be very prevalent, up to 30 to 40%. Okay. But in patients that we see, we don't routinely do the ambulatory blood pressure monitor. So are they really having resistant hypertension? Okay. And we have to really look at this carefully. Now, what's interesting is, remember, there was that resistance, and then there was that subgroup of refractory hypertension, those that are very difficult to treat. Now, in the patients that have refractory hypertension, instead of 30 to 40% of white coat effect, there's only 6.5%. It's much lower. So in these patients, they tend to have less of a white coat effect. It's most likely a very real value. So what can we do about this? Okay. So the first thing is that sleep insufficiency does correlate with higher blood pressure. So this was a paper in 2014 looking at resistant hypertension and sleep apnea, and the use of CPAP reduced blood pressure by 7/6 millimeters of mercury. This is the Hipparcos study, more recent, that looked at patients with both resistant and refractory hypertension, looking at the use of CPAP versus no CPAP to treat the sleep apnea. What they found was in resistant hypertension, there wasn't as much of an effect. But in refractory hypertension, there was a great effect. And remember, this was increased sympathetic activity. Again, you get no oxygen, sympathetic flow is even increased further. These are the patients that really might benefit from using CPAP. Okay. So he then talked about how to treat resistant hypertension. So again, you use ACD, an ACE, an ARB, plus a calcium channel blocker, plus a diuretic. Your fourth drug should be to add a mineralocorticoid antagonist like spironolactone and eplerenone. If they still do not have control of their blood pressure, the recommendation by the HA is to look at the heart rate. Again, if their heart rate is high, you add a beta blocker. If it's lower, you add hydralazine or an alpha blocker, and you can consider other medications as well. So the first step for resistant hypertension is to add a mineralocorticoid receptor antagonist. So this was demonstrated in the REHOT trial, where again, in resistant hypertension, the comparison was between spironolactone and clonidine. And we can see that both medications reduce blood pressure by ambulatory monitoring, but spironolactone does it to a greater degree. Okay, so here's the change in systolic and diastolic, significantly greater in the spironolactone arm than the clonidine arm. And there are other trials that show exactly the same thing with different other comparator medications. So again, a mineralocorticoid antagonist, the first step that we're going to add as a fourth drug. Okay. So what about the use of device therapy to try to treat resistant hypertension? So we have two things that are really being used right now. We're using renal sympathetic denervation, where the sympathetic nerves are ablated to try to reduce sympathetic activity. And we're also using carotid baroreceptor stimulation. So stimulating the carotids will then decrease sympathetic activity as well. So these are the devices that are trying to be used to treat resistant, and we'll see refractory hypertension. Okay. So Dr. Peixoto talked about the various different devices. Here's renal denervation. Here is again that carotid stimulation. And I just sort of summarized some of the effects. The Simplicity trial, although uncontrolled studies seem to show a great benefit, when you compare to the sham procedure, it really did not show significance, and perhaps the ablation was not complete. Okay, in a meta-analysis, we see a reduction. The baroreceptor trials seem to have a greater reduction in the blood pressure, but these studies are uncontrolled, and they're randomized trials that are going on right now. Okay, so what about using renal denervation for resistance and perhaps refractory hypertension? Okay, so this was the Prague 15 trial, 106 patients with resistant hypertension, and this looks specifically at adding renal denervation or a pharmacologic agent, some medication, which was over 60% of the time an aldosterone antagonist. Okay, so here again is renal denervation. Here is the medication. And we can see that at 6 months, there is no change in the sympathetic, in the systolic or diastolic blood pressure between the denervation and adding a medication, most of the time, that being spironolactone. So it was no better than spironolactone. All right. So this is the Diener hypertension trial. So what they did was they had their 3 medications, and then both arms had step care. So they both had spironolactone added to the groups. One had then more medical therapy. One had, in addition to spironolactone, renal denervation. And what we can see is that in this arm, the renal denervation arm, they did drop blood pressure to a higher degree than the medical therapy by itself. So if you add renal denervation to spironolactone, this might be beneficial. And remember, those with refractory hypertension, increased sympathetic activity, perhaps this would be the thing that might help these patients in particular. And so what they found was, again, that the control rates on a 24-hour were better. The daytime wasn't much different, but the nighttime was significantly improved in the denervation arm added to the spironolactone versus spironolactone and other medications. So this may be, again, where we use renal denervation. Adding the 4th drug, and especially in that refractory group, perhaps using renal denervation. Okay. So again, just to sum up, with refractory hypertension, we want to make sure there's adherence to try to use the blood pressure monitors if we can, the ambulatory 24-hour blood pressure monitors. Again, with refractory hypertension, they have even a higher incidence of non-dipping. Resistant might be 40 to 50%. Refractory, they're up to 70%. Again, to look for sleep apnea, we talked about the medications. You know, spironolactone is that first medication after the first 3, and then other medications. And again, thinking about perhaps a place for some of our device therapies, either the renal denervation or the carotid sinus stimulation. Okay. So lastly, I was going to speak about hypertension in dialysis patients by Dr. Rahman. Okay. So we know that the mechanisms for hypertension in dialysis, it's usually sodium and volume overload. There are other things involved, arterial stiffness, increased sympathetic activity, but volume is, we know, the main thing with hypertension in our dialysis patients. So one question would be, what blood pressure measurements should we use to correlate best with our cardiovascular outcomes? Is it the pre-dialysis blood pressure, the post-dialysis blood pressure, home monitoring, or the 24-hour ambulatory monitoring? So the first thing I want to tell you is that, again, this is, again, perhaps in China, you have better nurses, better ways of doing things. But in the US, we really have terrible dialysis readings, okay? So this was the difference between what the dialysis technician received versus a research nurse checking that same blood pressure. And what we can see is that the dialysis nurse gets a much lower blood pressure than the standard technician blood pressure reading. Okay, so it's much, much better. So again, what blood pressure measurement correlates best with cardiovascular outcomes? So this is, again, all-cause mortality. This is quartiles of blood pressure. So if there was a correlation, we should see a line where the fourth quartile, the highest quartile, had the most correlation with all-cause mortality. And what we can see is whether we use pre-dialysis blood pressures, post, whether it's done by the research nurse or by the technician, it really doesn't matter. Nothing correlates very well. However, if we have the patients do home blood pressure monitoring, and especially 44-hour ambulatory blood pressure monitoring, what we see is there's a much greater correlation with cardiovascular events. And these were just the optimal blood pressures with home monitor and ambulatory blood pressure monitoring. They did the best as far as outcomes. Okay, so what is our target blood pressure in hemodialysis patients? So here are various guidelines: the 2005 KDOQI, the Canadian 2006, the Japanese 2012 guidelines, all target, let's say, a blood pressure of less than 140/90. However, the more recent KDOQI guideline and the European EDTA guidelines say there's really no specific target because there is no data to show one blood pressure is better than the other. Okay. So it's really unclear what should be our target blood pressure in dialysis patients. Okay. So this was a pilot trial trying to find that answer. So this was looking at pre-dialysis blood pressures, targeting either 155 over 165 versus 110 to 140. And the question is, would this lower blood pressure then improve mortality and other events? Again, this is the pilot trial to try to go through with a larger scale trial. But what this proved was this could be done. You could see that separation. Now, unfortunately, really the lower blood pressure did not lead to really improved outcomes. This was the combined cardiovascular event, little lower hazard ratio, but not significant. However, the lower blood pressure target led to more hospitalizations, more vascular access thrombosis, cramps, nausea, vomiting, etc. So really, at least in the pilot trial, we did not see an improved outcome with the lower blood pressures in our dialysis patients. Okay. So again, what we try to do is limit intradialytic weight gain, watch sodium intake, make sure that we have an adequate time to remove the extra fluid. And again, the key thing is to try to achieve the dry weight on dialysis, that magic moment where we get the blood pressure down, but we do not cause cramps, hypotension, really what is that ideal dry weight? Okay, so what is one way that we might be able to use technology to achieve this dry weight? So this was looking at the use of lung ultrasound in our hemodialysis patients. Okay. So what they did was, using lung ultrasound, they looked at the number of B lines. Again, the B line is a symbol or an indication of fluid overload in the lungs. Okay. And they looked at cardiovascular disease and those without cardiovascular disease. And if you didn't have many B lines, you did not change the dry weight. But if you had more B lines, you would lower the dry weight by 0.1 kilograms. If you had more, it would go up. If you had even more, it would go up with each session. This continued after week 1 and after week 8. Okay. So again, depending on your B lines in each treatment, what do you do with the dry weight? So these were the results after 8 weeks in 71 patients. Here is the B line score. And again, with the ultrasound, with reducing the dry weight, there were less B lines. The dry weight went down, although only by 0.71 kilograms. It went up by 0.51 in the group that did not have the lung ultrasound. But look at the blood pressure change. By just reducing at 0.71, there really was quite a nice reduction in blood pressure. And I guess with each individual treatment, you can then determine what to do with that dry weight. Okay, so for some of our patients that really have very hard to control hypertension, this might be a tool we might be able to use to lower blood pressure. So what about outcomes? And I'll just go through this very quickly. This was a trial comparing atenolol with lisinopril. There were reduced cardiovascular events using 3 times a week atenolol versus 3 times a week lisinopril after dialysis. Carvedilol reduced mortality versus placebo in those with a dilated cardiomyopathy. Calcium channel blockers reduced cardiovascular events compared to those placebo in our dialysis patients with hypertension. I'm not sure that's very surprising. Okay, so what about the use of diuretics to try to increase outcomes, to improve outcomes, to preserve residual renal function? So this was just using electronic records to look at patients that continued a loop diuretic versus those that did not, and they looked at hospitalization, intradialytic hypotension, weight gain, and mortality. And the question was, could we reduce mortality and these other measures? So what was found was that death, it looked like there was less of a hazard ratio, but was not statistically significant. There was less hospitalization. There was less intradialytic hypotension. So the thought process was perhaps this would be good for our patients to continue diuretics even after starting dialysis. Okay. Lastly, when we look at medications, most ACE inhibitors we know are removed by hemodialysis. Most beta blockers are, except for carvedilol and labetalol, and most ARBs are not removed by dialysis. Now, I think that many first-line or any first-line drug can be used, but this was the formula used by Dr. Rajiv Agarwal, an expert in dialysis and hypertension. He likes to use the beta blocker, atenolol, 3 times a week after dialysis. He would add a calcium channel blocker, and if that doesn't work, he'd add an ACE inhibitor or ARB. I think you could make an argument to change that order, but this is his formula about how to treat blood pressure. So in summary, we know that volume is the major contributor for dialysis hypertension, that accurate blood pressure measurements, those achieved or measured by the technician, are not always the best. The control of volume status, is there a way we can get to a dry weight? And perhaps the use of that point of care ultrasound might be really a focus in the future for those patients with severe hypertension. And lastly, most classes of drugs can be used in our dialysis patients. We know that some get dialyzed off. So I'm sorry, I think I took a little bit of time over my time frame, but I wanted to thank you all so much for allowing me to speak to this great group of nephrologists.